First of all, I would like to acknowledge, with respect to the history, customs, and culture of the Lekwungen people, comprised of the Esquimalt and Songhees First Nations, on whose land we live, work, and meet today. And acknowledging the territory is a way of marking colonial history and the relationships that we have in perpetuating the harms and inequalities that have been experienced by Indigenous people through the basically last century and more. Now, in terms of why we're here, this is K2A, unlike Y2K where nothing happened. This is going to be something that's actually going to happen. And this is actually a very exciting event. And that's part of Island Health's Knowledge to Action, or K2A month. And it's hosted annually by research. And the K2A month seeks to celebrate and share importance translating evidence into practice. And I really can't emphasize that enough, to be able to take the science and make it applicable to the real world. And this is a chance to improve not only our knowledge, but eventually, hopefully, improve the care and understanding of what we're doing, and ideally improving outcomes. Now, it's my pleasure to introduce Dr. Bernie Pauly. She's an associate professor at the University of Victoria School of Nursing and a scientist at the Canadian Institute for Substance Use Research. She is also, and this is where we think is the really important title, Island Health Scholar in Residence. Though I've never been able to find her house on this property. I thought that came with the house, but apparently it doesn't. And a University of Victoria Provosts Community Engaged Scholar, and I think with the emphasis on engaged. Her research focuses on reorienting health and social systems to reduce health inequalities and prevent the harms of substance use. Now, as a nurse and educator, Dr. Pauly is recognized for her passion and commitment to improving the health of people marginalized by society. And I certainly, as somebody who's known Bernie for a number of years, we've gotten out of actually specifying how many, because then people say, aren't they a little bit past it? But no, in Bernie's case, she's absolutely with it. And I think the other thing that frames it personally, frames it for me, and this is sort of the more somber in our conversation beforehand. I told her we had a really good weekend in terms of the island, in terms of overdose. Only 3 people died this last weekend of overdose in their homes. And again, it was this whole phenomenon of us becoming so accepting of what is actually a tragedy that continues to unfold day after day, week after week. And again, I think this is why I'm so excited and really looking forward to hearing Bernie's presentation and others. And my understanding is we're going to pass the baton in terms of presentations. Bernie will have the privilege of introducing the speaker that follows her. Thank you very much.
Great. Thanks, Richard. I think he said I'm cool. Which is, that's my aspiration. I have 2 teenage children, and I'm always checking in with them, and they repeatedly tell me that I'm not cool. So I'm always looking for evidence to counteract that. I think when, in 2015, when we started to see the rise in overdoses, working in the community, I didn't see it in numbers, I saw it in people. And it has felt so real for so long. And as a researcher, you're always thinking about what can you do? What can you do to help within your professional capacity? So when the Canadian Institutes of Substance Use Research put out a call for what they wanted were very fast, quick reviews of the literature, they're called scoping reviews, we immediately responded and thought we had a really good idea about looking at the literature in a different kind of way, which we'll tell you about in a minute. But they gave us a 6-month timeline. And in research, that's like a nanosecond, pretty much. So we were so fortunate. This is the amazing project team that includes librarians, it includes other faculty, it includes graduate students. Some are here today. Lacey Mesley is with us. And my good colleague from nursing, Karen McKinnon, is here, and she's going to co-present with me. But we brought this whole team of people with different levels of expertise, including people from Island Health. You'll see Diane Sawchuk and Wendy Young were involved. And we were actually able to do this in 6 months, and we just submitted the final report to CISUR not next week, 2 weeks ago, actually. So to present with me is Karen McKinnon, and she's an associate professor in the School of Nursing at the University of Victoria. She teaches both undergrad and graduate nursing students, and her program of research explores the social organization of health experiences and the work of childbearing women and nurses who provide maternity care for women and their families, with a special focus on rural nursing. She's also the co-director of the Joanna Briggs Institute Evidence Synthesis Center at UVic, and is now a certified trainer for JBI's Comprehensive Systematic Review Program, and co-leads that now with Diane Sawchuk from Island Health. So we were very fortunate to be able to put together a team that had all of this sort of content expertise with all of this kind of technical expertise. So what Karen and I are going to work together on this, but what I'm going to do is introduce kind of the topic and kind of how we focused our review, and then Karen's going to talk a little bit how we did it, and then we're going to share some of the findings. I'd also acknowledge our funder was the Canadian Institutes of Health Research, and even on this short timeline, we were able to engage to a degree a number of really important project partners who helped us in terms of informing the project, but also helped us in terms of interpreting some of the findings. And I can tell you that's no small feat on a 6-month timeline, the willingness that they had to do that. And we actually held a meeting in September to review some of the findings with all of our project partners that were on the grant, as well as a few additional people. So when we think about the current overdose epidemic, and we all, you can't not know about it in the media, is the part we don't often talk about is the fact that while overdoses impact, it cuts across the population. It's not in any way restricted to one segment of the population. But the part we often don't talk about is there actually is what we call a social gradient, in that there are certain communities and groups who bear a higher level of overdose rates than others. So we came up with this in terms of just like there's a social gradient in health, that same social gradient is in overdose epidemics. And so you can think about, the currently unsafe drug supply that we have because of current drug policy. That impacts anyone who accesses that. It doesn't matter what your income is. It doesn't matter what your gender is. You are at risk if you're accessing the unsafe drug supply. But then we have things like changes in opioid prescribing, which affected, certain people more than others, people who were already identified of having a substance use issue. We've had long in BC, we've identified that we have insufficient treatment systems. That's not new, but that plays into it. People not, being able to get access to treatment. And then when we go even further, you can look and say, the disproportionate impact of overdoses felt by people where there's insufficient social determinants of health, like housing. If you look at the data from First Nations Health Authority, you see that Indigenous people are 3 to 5 times affected by overdoses. When you look at issues related to criminalization, and there are gender differences as well, and you can see that men are disproportionately impacted as well. So there's a social gradient in this overdose epidemic. Is this something new? I'm going to tell you it's not something new. If you look at the HIV epidemic, which spanned through the 80s, 90s, into the 2000s, we had the same kind of social gradient in HIV epidemics. So what's going on? This diagram is kind of our attempt to say that a lot of times the way that we kind of focus our efforts is on the specific identified issue like overdose or HIV or addiction, and we don't actually look at some of the other harms that contribute, like injury, violence, stigma, social inclusion. And we don't often think about as much the broader context in which that harms occur. So that's in terms of the yellow: poverty, homelessness, colonization, racism, gender norms, sexism, heteronormativity, criminalization, which produces stigma, ageism, trauma, and intergenerational trauma. That's an outcome of some of the other outcome of colonization. So when we're talking about health equity response, we're not just talking about kind of looking at the symptom, we're looking at the context in which the symptom is exacerbated and manifests. So inequities are not simply bad luck. They're systematic, they're socially produced. Therefore, and this is the good news in it, we can do something about it. So we're not talking about what's wrong with people, we're actually talking about what's wrong with systems that's making this happen. And just to be really clear, we're not talking about responses that are equal, i.e. everyone the same response. We are talking about creating equitable responses. So equality, everybody I use this one because everybody in my family bicycles, and I think about bicycling all the time because I'm thinking about, who's going to get injured, or am I going to have to use Island Health today? Those kinds of things. Fortunately not. But equality is everyone has the same bicycle. Equity is you have a bicycle that's tailored and suited to your needs. And if you take a bigger look at this, what's the context in which whether or not people can have bicycles, and what do bicycles even mean in that context? Someone told me on Saturday that in Ecuador, bicycles are a luxury item, not an essential item. You can think of countries where they'd be an essential item. So we have important distinctions, but we're focused on equity. And that we said this is about systems, and a really important part of equity is reorientating health systems toward health equity through action on the social determinants of health. That's an international standard expectation, to look at our systems in a different kind of way to produce equity, knowing that systems produce inequities, they can also produce equity. So here's where we come in with our review. Is a lot of the people on our team for a long time have been working around concepts of equity, around culturally safe care, trauma and violence informed care, and harm reduction. And some of our good colleagues at UBC, Colleen Varco and Annette Brown, they sort of put together these concepts and said, together, these are like health equity oriented interventions, and that they should be universal. So what they mean by that is that cultural safety, trauma and violence informed care, and the principles of harm reduction should all be applied and are applicable universally. They're not specifically applied to one population or the other, which is often how we kind of do this. And we recognize that we're doing all of this work in the context of decolonization and the commitments that we have as nurses, as health authority staff, practitioners, educators, and others, our commitments to decolonization in our healthcare systems. However, we have kind of a fundamental problem, is we have these concepts which make up what we could say are equity-oriented responses, but we have a lack of knowledge and guidance as to how to integrate or incorporate these approaches in policy programs and practice in alignment with health equity, social justice, and decolonizing approaches. And where that really comes from is because I work a lot in the community, and people will say, well, we're doing cultural safety training, or we're doing trauma violence informed care training, or we're doing, harm reduction. But the question is, how do we put those together in our practice and in our policies in a way that's actually meaningful? And so we thought that was a really good kind of question to ask, specifically around how we respond to overdoses. I'm just very quickly, because one of the other issues is often people go, yeah, those are great ideas, but what do those actually mean? I'm just going to quickly run through 3 concepts that we could do a whole session on each. But the concept of cultural safety originated in New Zealand. It was developed by nurses to address the unmet healthcare needs and systemic racism that was impacting health and healthcare of Maori people. It's been adopted worldwide to address the unmet needs of Indigenous people in Canada, and many Indigenous organizations and leaders throughout the country have been promoting cultural safety. If you remember nothing about cultural safety, I want you to remember that whether or not a place, a program, a space is culturally safe is defined by those who receive the services. says, oh my God, that's a typo. Whether a place is safe. Yeah, I thought it was a typo. It's not. Whether a place is safe or not is defined by those who receive the services. So remember that. It doesn't matter if I, Bernie Pauly, think as a nurse that I'm doing a good job and I provide culturally safe care. I can think that. It makes me feel good to think that. But the reality is, what matters is when people come to receive care, do they feel safe? Because there are so many things that I, as a nurse, as a researcher, am completely unaware of that are unsafe for people when they come in their context. So we actually have worked with this concept a lot, and we have done a couple of different projects specifically to look at the idea of cultural safety in relation to reducing drug-related stigma. And one project was in hospitals, that's the one on the right. The other project on the left was in collaboration with Island Health and a number of community partners, and it was to do with primary care. And you can find all of that on our CISUR, Canadian Institute for Substance Use Research website. Trauma and violence-informed care, we're not talking about treatment for PTSD, but we're talking about how those contexts of harm, things like colonization, like current drug policy, how those many layers can affect people's ability to engage with providers and the care they provide. So we're talking about trauma, and as my colleague Colleen says, trauma and violence-informed care, because it helps us to remember those contexts that produce the harms. And I think many people in this room are familiar with harm reduction, but there's a little distinction I want to make. When I talk about harm reduction, I just don't talk about the intervention of needle exchange or distribution of naloxone. I'm talking about a philosophy, a set of principles that say, I accept you regardless of drug use. And it's about philosophy, programs, and interventions that treat people who use drugs in a more respectful, compassionate manner while keeping them safe. That's the most simplest kind of way I think we can say it. So I'm going to turn it over to Karen, who's going to tell you about the scoping review we did to try to generate some insights in what an equity-oriented response is and how we did it.
And I'm going to do this fairly quickly because I'm sure you're all wanting to hear about the findings rather than how we got there. But I will just walk us through the process. So this is our research question. What is currently known about the use of a health equity-oriented approach for preventing the harms of stigma or overdose? And stigma we added along the way. When people use illicit or street drugs or use prescription drugs for other than their intended purpose. And this is a bit of a map. We were very fortunate. We were able to pull 2 research librarians from the University of Victoria, one of whom has a lot of experience with our JBI process, Dr. Carol Gordon, and another who's been involved in quite a few scoping reviews with Island Medical Program, Rebecca Roberts, and they were very helpful in helping us put together a search that made sense. This is a little bit different than a straightforward sort of biomedical search where we're looking for a particular population. We're looking at some fairly complex concepts here, but this slide gives you a bit of an overview of how that played out, the context being overdose and drug-related stigma, illicit opioid or drug street use, prescription misuse is evident in our question. And then we were looking specifically for approaches or frameworks that had at least one of these concepts in them: cultural safety, or harm reduction, or trauma and violence informed care. So there's a lot of ands and ors in this search. And then we also wanted them to be congruent with a health equity, social justice, or decolonizing perspective. So that was also more search terms that we used. And then we were interested in using the results of this study. So we very much wanted to look for frameworks, guidelines, principles, models, action plans, etc. We also were interested in all of the preceding that focus specifically on Indigenous communities because we wanted to see what was out there for some of our practice partners that focus there. And this, for those of you that look at lots of systematic reviews, will look very familiar. It's our PRISMA document, and the black text is the peer-reviewed literature that we found, and the blue text is the gray literature that we found. And I'll make this very short. As you go along, you'll see the important part is once we've screened for relevance to our question, we wound up with 102 peer-reviewed papers and 13 papers from the gray literature. I'll just highlight, in the gray literature, we were primarily looking for frameworks because that's where some of that material resides. And this is just a quick review. Scoping reviews, of course, map what's out there. So these are some slides that sort of highlight what's out there and where we found what we found. A lot of it is from North America. In fact, Canada is kind of leading the way. I would go so far as to say that British Columbia might be leading the way in some of this research. So that slide gives us a sense of the global reach. We did find 5 papers that were published not in English. It requires an English abstract because we were limited in our resources. And we just tallied that for this point in time. But we do have some identified. Research articles by approach. So again, we were looking at cultural safety, harm reduction, trauma and violence-informed care. And rather than looking for research that studied Indigenous people, because that's what everybody does, we were more interested in research that was informed by an Indigenous perspective. So research or a framework that is constructed in a different way. So that took us a little while to get our heads around. This is by methodology, and what you'll see here is that the research is overwhelmingly qualitative. At the bottom of the slide, we've broken out 3 different qualitative methods: community-based research or participatory action research, ethnography, and other. And that's the lion's share of the literature at this point. We did also find some policy or discourse analysis papers, some mixed method studies, some quantitative studies, some knowledge translation studies, and some commentary that we included in our mapping of the literature. By population, if you look at this slide, you'll see that the majority of these studies focused on service users. So we've got good qualitative data that in many ways captures the perspectives and experiences of service users. So I think that's a good thing. Often we don't find that when we're doing reviews of the literature. Next, most common would be, well, it's not specified, where they're not actually focused on the population per se. And then service providers. The group that nobody has studied very much are policymakers. Research by setting. Again, this kind of care is provided in a variety of settings. Hospital. Yes, I know. Right. Opioid system. I'm the methodologist, not the substance person, but I work with a great team. There's a lot with harm reduction, which I don't think will surprise the people in this room. I think it's gotten a lot of attention. Some peer-run papers, some done in prison or post-prison settings, and some, again, that weren't specified. And our gray literature papers, which there are fewer of, if you go back and look at the Prisma diagram again, I'm just trying to remember, I think there were 13 of them. You'll see that these totals are more than 13 or more than the 102. And that's because some of them had more than one approach. So just to clarify that as you're looking at it. But from our gray literature, where we were looking specifically for frameworks that were trying to integrate these concepts, there were 9 that were harm reduction, 6 cultural safety, 3 that focused on trauma and violence-informed care, and just 1 from the gray literature that was informed by an Indigenous perspective. I think we had a total of 5 altogether, if I remember correctly. There it is. I did remember correctly. And so that was an additional question that we asked of the literature. And like anything on a tight timeline, we had to put some parameters around things based on time and resources. But we were very much interested in frameworks and approaches that have been informed by an Indigenous perspective, because it's something we haven't done a lot in the past. So those are our additional questions, and I'm going to turn it back to Bernie and let her do the part you came for, which is the results, right?
That was already a good overview of the results. There's a couple of things that I'll mention about what we found. There's some limitations in it, in that we had to define the question specifically in relation to overdoses. So there's a lot of Indigenous perspectives and knowledge that would not have been brought to bear on this question. So that's an important kind of limitation. And then even the JBI kind of process, we've had a lot of conversation about this, wanted us to focus in on people, not or populations, not so much on what health equity is about, which is the structures and the systems. And so we had to do a bit of thinking to make it fit. But we did something really interesting that I think really gives us a lot of information to try to think about policy and practice from this review, even though, there are limitations obviously in that we didn't assess all of the evidence in terms of quality, because you don't do that in a scoping review. It's meant to gather everything. What we did is we looked across all of those 102 articles that got included in the review, and we pulled out anything that they said about recommendations. So we have these long tables, like every article and what they said in terms of recommendations. And that's when it got super interesting, because there was so much, in many ways, so much collective wisdom there, that we decided to do more with it than we had actually intended to, because the scoping review pretty much could have stopped where Karen stopped and said that's what we found. But what we found in those recommendations, first of all, was 6 overarching themes, or sorry, 5. There's one I'm saving for later. I mean, clearly everybody is concerned about stigma and how that influences overdoses and people's access to services. But what's really important is that there was general recognition through the literature that stigma is being produced by our current drug policies and producing harms to health and well-being. And it said pretty clearly. And if any one of you follow international drug policy, on Monday, the International Drug Policy Coalition, IDPC, I think it's Coalition, actually did a panel, produced a report where they laid this out so beautifully at the international level, the way in which, current focus on prohibition is contributing to health and social harms, including overdoses. The recognition across the literature of the social and structural factors, colonization, historical ongoing trauma, racism, discrimination, particularly impacting Indigenous peoples. And then here comes the really super hard part. We can talk about and all agree that those are good principles of cultural safety, trauma, violence, informed care, and harm reduction. But it actually means we have to shift our thinking. We have to reorientate our values. And there actually is a set of specific competencies. Some of you may be familiar with the medical literature, which is talking about structural competencies right now at an individual level. This goes beyond that to talk about, what are the competencies, not just in terms of individual care and practice, but in terms of policies and programs. And that taking a health equity decolonizing approach means taking a multi-level, multi-layered approach. So we're not just talking about how am I in my interaction with a nurse when someone comes into the clinic. It's actually what's happening at every level in our health system. So that led to something very interesting. We said, you know what? We could map these recommendations onto a socio-ecological model. And a social ecological model really comes out of public health. And it talks about how is an individual situated in their context and how does that impact their health. And some of you will be familiar with Brofenbrenner, who kind of, developed that. But and it's been taken up widely in public health as a model because, kind of makes sense that there's more than just what we're doing in our behaviors that's resulting in poor health outcomes. For example, there's a lot going on. There's things at the interpersonal level, what kinds of social networks we have. We can think about organizations. Organizations I'm interpreting and using in this model as our healthcare organizations, and then community, what's happening out in our wider community, and then what's happening at the broad public policy levels as well. So here we're thinking provincial and national policy. So you can kind of see that a socio-ecological model would work pretty well for mapping on what an equity-oriented response to overdose is. I'm going to start from the center. The center is about shifting values across that whole system, but I'm going to start from the intrapersonal. In other words, how do practitioners orientate themselves? I could have started the other way, and I have to say I organized the slides like 10 times. Should I start from the bigger or start from the inner? So I started from the inner in terms of the intrapersonal. And I think it's easy. We all agreed to this in our profession, that we're not thinking about people as disease entities. We're seeing them as human beings. We see them as worthy of value in their own respect. I agree to that in nursing. My social work colleagues, my counseling colleagues all agree. And yet we have things happening because of stigma that actually do affect how we see people, how we do their assessments, how we treat them and respect them in our relationships. Even things like, the popular discourse of addiction as a disease. We start to think about people as a disease. That is not what they are. So that's at the intrapersonal level. In oneself, how do we orientate ourselves? And then in the interpersonal sphere, in other words, in our relationships, one of the most important things that kept coming out in the literature over and over again was the importance of the relationship and building trust. And while I didn't, I pulled from stuff that I've written years ago, it was just resonated so much that, we're trying to build trust in a climate where people are going to be distrustful. If you are using illicit substances, you are not going to feel safe to access services because there's always that fear of criminalization. And even though we know it's, you can say it's confidential, how do other people necessarily know that? And then you start to think about, well, what are some of the rules of things that happen when people do reveal substance use and how they're treated? So in the interpersonal space, the importance of trust and relationships. At the level of social networks, one thing that's incredibly important is contributing to the development of peer-to-peer networks of people who use drugs, networks of families, and networks of communities. Those are protective factors, and those are supportive factors. So those social networks, and we can, those are outside necessarily of healthcare organizations, but you can think about how do we contribute to that, particularly in areas like public health and community development, are really important kinds of work. So it's not just caring for the individual, it's actually at the level of families and communities and supporting the development of those social networks. In terms of, interestingly, the majority of the recommendations were for the organization, which I find quite interesting because, of course, it's a health equity approach. We're interested in structures. We're not interested in what's wrong with people. We're interested in how do we reorientate structures. The bulk of the literature was on harm reduction. So there were a lot of recommendations about ensuring you have harm reduction policies, ensuring that there's a culture and a philosophy of harm reduction, as well as the interventions and programs. And we often treat harm reduction as, we've done a lot of research in shelter and housings, and, it's often treated as, well, we're just going to drop in needle exchange, we're just going to drop in naloxone. But if those programs don't have a philosophy and a culture, or even at a practical level, policies, it's pretty hard to do this in a fulsome kind of way. There were a lot of recommendations around how do we do social inclusion. And this is just an example from other work I've done to really challenge us to think about, are we at the right-hand side, which is partnership, shared power and decision-making when we're working, with community members, when we're working with people who use substances, or are we somewhere further down kind of the continuum? And, I've often worked with organizations and they'll say something like, well, we ask our clients what they think. That's great, but that's not partnership and exclusion. You're at that far end. And then people say, well, we have somebody on a committee. Okay, that's good. That seems like a good start. But if you've got one person on a committee and you're consulting them, that's probably tokenism because they don't have the same power as everybody else on the committee. And then you can move along and say, we could have peer reps, we could have peer workers. That's good. And are the supports in place? We're doing a Health Canada project right now, actually looking at that very issue because peers don't have the same benefits as other first responders. They don't have an employee benefits program. So they actually have no supports. So we're actually developing an intervention right now. That's another project. And then are we actually building those peer workforce, peer organizations, peer network? That's a particular passion of mine because I probably spent the last decade of my life working with peer-run organizations. And so we have some thinking to do about what this really looks like in organizations to have real and meaningful peer involvement and inclusion. In terms of our spaces and our services, thinking about, and this is at the very practical kind of level, to what extent are we integrating and expanding OST, supervised consumption sites, naloxone? We have those things. BC is doing an amazing job, but we don't always have reach. We don't have them in every community where we need to have them, largely often because of community opposition. How are our pain management protocols? Are we dealing, that's a good example, so that people are getting addict pain relief. They're not accessing the illicit market. Are our spaces non-judgmental? That's where cultural safety, trauma, violence informed care comes in. And there's quite a lot in the literature that's quite interesting about how you set up services so that people have privacy, but they're not segregated. So it's simple things like when someone comes into primary care, you're not asking them in the waiting room, what are you here for? If we could change that one practice, that would change a lot of people's lives. Because you have to out yourself sometimes if you're here for a particular, if you're here, I'm here because I'm concerned about an overdose. Yeah, it's hard to say that. And then this information around seeing your staff as advocates and activists, because they have to raise questions. And I don't mean this in a negative, way, out marching in the street. What I mean is, do people feel safe in your organization to ask questions about policies? To raise, how do we refer to people that come here that use substance? What language do we use? Is that language okay? That's what I'm talking about in terms of advocacy and activism. And I know there's lots of people in the room who are super good at that. And then in terms of healing approaches, and this largely comes from the Indigenous literature, the importance of understanding and addressing cultural needs. There was a bit of international literature as well. Traditional medicines and Indigenous cultural practices, opportunities for cultural connection and reconnection. And then it broadly creative means of expression for promoting health. So incorporating healing approaches into how we do programs. And then education, there's quite a few recommendations here about, and this is education for people in the system. We all need to understand that history of drug policy. That's like, to me, cultural safety 101. Everybody needs to understand drug policy, the harms and impacts of that on substance use, knowledge of benefits and effectiveness of harm reduction interventions, whether you deliver them, support them or not. Everybody needs to know that. Structural competency, where we recognize the broader structural stigma. That's actually, there's a set of competencies around that. Clearly, cultural safety training at all levels in the organization, involving peers in the kind of staff education we do, training in sociocultural understanding of inequities, in other words, how are inequities produced, and using social justice frameworks in our education and practice. At the community level, really interesting set of recommendations. We normally monitor how many overdoses are occurring. We might monitor some demographics, but do we actually monitor those structural conditions, those contexts of harm that I was talking about? So it's really shifting our heads in even public health and population health, how we think about monitoring. And then monitoring some things that we may not think about monitoring in our usual epi approach to surveillance, monitoring things like media and representation and stereotypes, and calling the media every time something happens. I had a really interesting experience last week. Someone from the media called me. I told them what I thought, decriminalize, drug policy reform. We had a good conversation, and he wrote the piece, and he did a great job. So I wrote him back. Now he's calling me all the time. I have totally can influence what way these issues are framed. That's the only reason I really do media, is because I like to be able to influence how they present, and they don't always get it right, so then I tell them. So I kind of do my own media monitoring. Policing, monitoring policing. That's a very interesting one to think about. And addressing inappropriate policing. And a specific recommendation was specifically around inappropriate policing. And I think around Indigenous people, and you can think about, some of the cases in Canada, and the reason why that makes absolutely perfect sense, and people not receiving the care that they need. Police training and harm reduction. So there is a role for police, but it looks quite different than what I think sometimes we would think of. And then addressing at the community level stigma and stereotypes through positive representations. And then something that's already happening largely in BC around developing community teams to deal with these kinds of issues. So now moving to that very last and outer level of the public policy recommendations, pretty clear cluster literature, moving to decriminalization where purchase and possession for personal use does not come with prosecution. And I mentioned already the IDPC, and it is the International Drug Policy Consortium, put out this report, Taking Stock, A Decade of Drug Policy. It is a fantastic report, and I'd highly recommend if you really want to get a handle on, kind of drug policy and what we're advocating for and why the harms, how the harms are produced. It does a good job of doing that. And it's because they looked at the last decade. They reviewed the last decade, because in 2019 will be the new goals for the new social development goals, and the drug policy recommendations will be more linked to that. But there's other public policies as well. The Good Samaritan Act, now in Canada, that came into effect in May 2017. But what we've discovered is that a lot of people still don't know, particularly in smaller communities, that if you call 911, the police will not be called, should not be called, and you should not be reported if there are illicit drugs when the ambulance arrives. So the Good Samaritan Act in effect, but we need to spread the word. Harm reduction obviously is federal policy. We could talk about when it wasn't federal policy, which was actually not that long ago. It's just been returned to federal policy, but we have a large national policy project, and we've mapped harm reduction policy all across the provinces. It's led by Elaine Heischka in Alberta. And what we found is while BC has very good harm reduction policy, best of the provinces, there's still a bit of a patchwork, and it isn't always at every level. You can think about at the organizational level, harm reduction policies are often inconsistent. Inclusion and social engagement. Social inclusion and engagement frameworks. If you think back to that little continuum I have, we need some frameworks to serve. There are frameworks out there, but we need to adopt those in organizations. Obviously, a focus on structural interventions related to poverty, housing, and violence, and centering Indigenous knowledge and approaches to wellness, as well as knowledge of lived experience. So the beautiful thing is that all of that came out of the recommendations. It beautifully mapped on the socio-ecological model, really highlights what we need to do to reoriented health systems. But we've been working in one of our other projects on what does this actually mean to look at the whole system through a health equity kind of lens. And from that project, one of the things we identified is 4 health systems actions: health promotion, health protection, disease and injury prevention, and surveillance. So when we talk about an equity-oriented public health approach, we are often talking about bringing into play public health strategies such as health promotion. So when you think about things like building peer networks, building family and community networks, and healthy public policy, that's all laid out beautifully in the Ottawa Charter for Health Promotion. From the recommendations, monitoring and surveillance, not just of sort of traditional epi, but monitoring and surveillance of some of the structural determinants. When we think about health protection, we can think about protective environments where everyone has training on cultural safety, trauma, violence, informed care, and harm reduction all the way through an organization, from people who are working in the kitchen to people who are making the major decisions at executive level tables. And most harm reduction organizations will tell you that has to be done. And then in terms of prevention, and again, remember the literature was overwhelmingly from around harm reduction, is more even implementation of some of those harm reduction strategies that we know will make a difference. So I'm going to stop there, and I hope that gives you a picture of what an equity-oriented response would be and what it adds to all of the things that we're already doing, but we still have definitely work to do. And so Karen and I would really welcome your questions. I think we have about 12 minutes or so for that. And throw questions at us. It's a scoping review. It's what we found. It's how we made sense of it. So we're totally open to challenging us and providing your insights. Thank you.